just Epistaxis, but it's a recent journal from an emergency medicine. It's a recent article from an emergency medicine journal. And whenever I was looking for articles that we might want to go over for Journal Club, I was trying to think of something that I thought that we could really learn a lot from, especially the M3s that are trying to learn so much about medicine at once and like eventually prepare for our EM rotation. And then the fourth years too that are doing their EM rotations and trying to prepare to become successful residents. And whenever I saw this article on Epistaxis, I kind of thought about it and I was like, well, I feel like in the first few years of medical school, we don't really talk about Epistaxis very much and like the management of it. We don't really talk about it on rotations so far. And so I feel like it's something that you're definitely going to see, because who hasn't had a nosebleed, honestly? And it's something that can be really simple or really complicated. And so I feel like it's something that can definitely make you stand out if you know how to manage epistaxis properly, and if you really take the time to learn about the different causes and the different treatment techniques and how far it can go as far as management. So let me try and move this video thing. Okay, so for the questions for today, the things I'm going to go over are, what is the anatomy that's associated with epistaxis? Because if you're like me, that's a little rusty. What are the possible causes for epistaxis? And then what is the management cascade for epistaxis in the ED? So for the anatomy, this is a picture from the article. It just goes over kind of the background anatomy, but basically to classify a nosebleed, there are two different kinds of epistaxis. There's anterior and posterior. And the anterior is going to come most likely from Kieselbach's plexus. And that's kind of where the internal carotid and external carotid branches meet at the front of the nose. And so those kinds of bleeds that you're going to see are going to be smaller vessels. And so they're going to be more easily controlled, and they're going to be more easily compressible. And so you'll oftentimes have less bleeding, and those will be bleeds that are more often to stop on their own or stop with compression over time. Then there are also posterior bleeds, and the posterior bleeds come from the sphenopalatine artery, the maxillary artery branches. And so those bleeds are a little bit more challenging just because there's often more blood there, and it can be a little bit more difficult to get the blood to stop and achieve hemostasis. Additionally, with a posterior bleed, there's an increased risk of aspiration at that time. So you might have a patient that also ends up like choking on the blood or coughing up some blood at the same time because the bleed is so far in the back of their nose. So whenever you are looking at epistaxis, one of the things that it really harped on in the article was how important it is to try and visualize the bleed and visualize the source if you can, because it'll give you a better idea of what kind of bleed you're dealing with and how much treatment it's going to take and where you need to kind of localize your treatment. So I put in a sample case so we could kind of talk about it, so I could see a little bit of what y'all thought about epistaxis and kind of y'all's history, if you knew anything about how to treat it. So our case is an 82-year-old male patient with a history of hypertension, AFib, hyperlipidemia, and coronary artery disease that presents to the ED complaining of a nosebleed for 4 hours. He reports that the improvement has been minimal with pinching of the nose during this time. He reports lightheadedness. He denies shortness of breath and chest pain. So off of that, what kind of assumptions can we make about this patient, or what can we glean from that information, which is very little information, like a lot of nosebleed cases will be?
I would be concerned about, I guess for me, with him having coronary artery disease and hyperlipidemia, if he's on any blood thinners that might be making the bleeding worse. That would probably be the first question I would ask, especially for him being 82 years old too. So I would want to stop that sooner than later.
Yeah, I think that's really good because the medications they're on, such as blood thinners, can contribute to this, and it could be a possible cause for that. So that's definitely a concern to look at. Anything else?
So I think this. Go for it, Mel.
I would. I'm not sure about how to treat this, but I would definitely want to get like a CBC and coag studies.
Yeah, definitely.
You can go ahead.
Yeah, take a further look at this patient's like hemodynamics and see what's going on there.
Yeah, I was just gonna tag along with what Paige was saying and add that this guy also has AFib as well as some other risk factors. So he's probably on like a true blood thinner and an antiplatelet, which means he's going to be really prone to bleeding, and we'll probably see that reflected all over the place in his coags and CBC.
Yeah. So that's just a case that I kind of made up just because whenever we're talking about risk factors and things that can lead to epistaxis, it's not just like the simple things. There's a lot of things that can cause nosebleeds. So let's try and come up with anything that could cause a nosebleed. What would be like something that's really common that can cause a nosebleed that most people would probably lean to as like one of their first on the differential?
Trauma.
Yeah, that's like people picking their nose.
Yeah, so trauma is really common. It's actually about 20% of nosebleeds that you'll see. So that's a really common thing that you'll find. And there's like a lot of different kinds of trauma. So there's like, like digital trauma, which you might see in children a lot. Then there's also like foreign bodies or different things like that can cause nosebleeds. What other things can y'all think of that can cause nosebleeds?
We had a guy come into a family practitioner clinic with like chronic nosebleeds because he moved into a house with a fan and it dried out his nose.
Yeah, definitely. So like environmental factors for sure can cause nosebleeds.
And you also need to consider that in the healthcare setting, whenever you put someone on nasal cannula, they're getting basically that same effect unless you're using humidified air. So on hospital day 3, you might have someone who suddenly starts having nosebleeds on your internal medicine or peds rotations.
I think that's a really good thought to think about too. Is there anything else that we do in the hospital that might cause someone's nose to bleed? So sometimes we will like put different things in their nose, like in addition to nasal cannula, sometimes on insertion of like NG tubes and stuff like that, there will be nose bleeding. Also, if we like give them medicines while they're here, like the ones that we talked about earlier or anything like that, they might develop it during their course. So there's a lot of different things that we do as like healthcare providers that can lead to nosebleeds. There are also, let me go ahead and switch to the next thing and I'll show you all some of the other things that the article talked about that can cause nosebleeds. So it mentioned quite a few that I never really thought of. I was kind of like, well, you either like get punched in the face and like that's how you get a nosebleed. But there's a lot of different things that can cause nosebleeds. One thing we definitely have talked about is drug use. So that can definitely cause nosebleeds over time, like snorting different things or putting different things up your nose. but not even just like illicit drugs, like different nasal sprays or things like that. If they're a chronic user of things like that, that can cause nosebleeds as well. There's a lot of also different metabolic things that can cause nosebleeds, like hepatic dysfunction, most likely because if they're like cirrhotic or something like that, their platelets are probably low too, and they're more prone to those kinds of things. Renal failure, uremia, and alcohol. Then there are kind of some of those common things that we talked about in HEMONC that can cause nosebleeds, like the blood disorders like von Willebrand's and hemophilia. There are also congenital things like septal deviation and different anatomical developmental things that can cause nosebleeds to be more prominent in your family. So they might have like a family history or something like that. Additionally, if they have different vascular abnormalities, like if they have hypertension or diabetes, that can cause changes in their vasculature, such as through like atherosclerosis and things like that, that actually lead to increased pressure in the vessels. And so that can cause bleeding overall. One thing I didn't know that it really talked about was that there's such a strong linkage with CHF and nosebleeds. And I was like, I've never seen a CHF patient described as having nosebleeds, but apparently there's a really strong linkage between CHF and nosebleeds, and the nosebleeds being recurrent because they have such increased pressure in their vessels for such a long time, that they're just more prone to that. And then we also talked about things that can happen because of us, like direct trauma, medications. If they have a cancer, they are more prone to bleeding, obviously. We talked about weather-related things like the humidity, different allergies can cause it. For example, you'll have some patients that will get them like at a certain time of year or things like that, like in the spring or the winter. And then if they also have like an inflammatory process, that can also cause a nosebleed. So there are a lot more things to consider than I thought there were whenever you're looking at that. So you want to take that into account whenever you're taking your patient history if they have a nosebleed, because there's a lot of different questions based off of this that you could ask to try and narrow down the cause of your patient's nosebleed. So whenever we are taking the patient history, obviously the first thing that we would want to do is kind of start out with what happened. We want to know if they did get punched in the face or something like that. We want to know what they were doing when it happened, anything that had changed at that time, how long it's been going on for sure, the quantity of the blood. Those can help you determine if it's an anterior versus a posterior bleed too. I think it's also important to know if they've had prior episodes of bleeding before, because that can help you determine the cause. If this is their first nosebleed, or if they've had nosebleeds every day for a month, or if they've had nosebleeds every month for their entire life, those are different things that are going to lead you to different possible causes for those nosebleeds. Like in our case study, you want to know if they have other medical problems or other medications, because those could be leading to their nosebleeds as well, or those could be things that can cause nosebleeds over time or contribute to that. So on review of systems, what other kind of symptoms would you want to look for in a patient that has nosebleeds to help you kind of narrow down different causes?
I guess easy bruising would definitely be one. Or like you were saying, like have they've always had problems with controlling bleeding or, you know, clotting and all of that stuff before. But definitely easy bruising would probably be one of the ones I would think about first. I'm trying to think of others, but somebody else may have something, so I'm just gonna.
No, yeah, I think that's really good. I think that can help you distinguish, especially if they have something that's like a hematologic or oncologic process. And also just like if they're bleeding anywhere else, like we definitely want to know if they're bleeding from multiple orifices or if they're having other kinds of issues like that. Anything else that y'all thought of?
Their vital signs and like kind of how they're acting can kind of give you a clue to see if it's like if they snorted anything or if it's drug use contributing to it. I think that's a UWorld question.
Yeah,
I would also
that's really good.
lightheadedness, just to see how much blood they have lost or how fast they're losing blood. Because like you said, if it's a problem in another area, that should, like a nosebleed shouldn't make you feel like super lightheaded and look pale or whatever the case may be. So that might be something I ask too, especially like I said with this man in the case, particularly being 84 years old, he's a little more fragile.
Yeah, I think that's good. Another one that I thought of was if they have like a rash or something else, like skin changes.
Yeah, I was going to add that in like these cases, we went through that huge thing where you have that like big differential with all these possible causes. So if you ever like stumped on what review of system stuff you should ask, just go through and ask what you would ask for like congestive heart failure or hypertension. So headaches, shortness of breath, chest pain, like just go through and knock all those things out because they'll help you whenever you're going back through and eliminating stuff out of your differential.
Yeah, I think that's really good. To kind of use like what you think it might be before you even enter the room to say, okay, what am I going to ask this patient to help me figure out what it could be? And then let that kind of guide your physical exam as well. So here's the big part. This is what it talked about for the most part during the article was the management of this. And I think this is the trickiest part because we don't really have any training on this. Like before we go into the third year, it's kind of like, well, you know a little bit about what to do for complaints that are taught on more like chest pain or shortness of breath or something like that. You have kind of an idea of where to start. But with nosebleeds, it's kind of like, I don't know, try not to make it bleed. So the first thing that it talked about in looking at your patient is determining if they're clinically stable. And y'all talked about this a little bit earlier. So what are things that would kind of help you determine if this patient is clinically stable or unstable?
Their mental status, their like if they're hypotensive.
Yeah, their vitals.
Yeah, for sure.
And you also, you have to make sure that this patient is like talking to you and breathing fine, because if they're chugging a lot of blood, then you have to make sure that they can protect their airway.
Yeah, so that's what I had. I had like tachycardia, hypotension, so like abnormal vital signs that are telling you about their volume status, respiratory distress or airway compromise. Like if you walk in the room and you say, hey, Mr. Smith, and he's not responding or he's choking on blood, you know, that's going to have to be something that you address immediately. You can't try to talk about his nosebleed and figure out what's going on. And then like altered mental status, like if they're getting confused or disoriented from the blood loss or from their disease process, then that's definitely something that would make them clinically unstable as well. And then we talked a little bit about how to distinguish anterior versus posterior bleeding, but just to kind of repeat that a little bit. So posterior bleeding is generally going to have more volume, whereas anterior bleeding is generally going to be less and more easily stopped. So whenever you have a patient that comes in with epistaxis, one of the things that can help them is their positioning. And so I know that whenever we get a nosebleed, we tend to kind of like lean back and compress, but that's not really good, especially if you think about your airway and where that blood is going. That's not really going to be the best positioning for your patient. So you want to try to have them upright and leaning forward so that you can protect that airway as one of the most important parts of managing the patient. Whenever you are examining the patient, one of the things that is going to be important is trying to visualize the source, because you can't stop bleeding if you don't know where the bleeding is. And so that's really important, and it recommended using like a headlamp or something like that, especially if it's more posterior. It might be a little bit more difficult if there's a lot of blood. You might have to try to irrigate it so that you can even try to see where the bleeding is coming from. Additionally, I kind of pulled this other mnemonic that they had that I've seen somewhere on an EM site that talked about epistaxis, and I liked it because it was epistaxis, and so that's very easy to remember whenever you're like trying to, you're in the ED and you're trying to, you know, impress these people, but you can't remember exactly what you're supposed to do. And so the first thing that you want to do is use pressure to try and relieve the bleeding. And more than likely your patient has been doing this for a while, but sometimes patients that might have never had a nosebleed before, or they don't really feel comfortable with what's going on, they're kind of just going to be like bleeding into a bucket or something like that. But a lot of times people will use pressure with their fingers just to try and relieve the bleeding on their own. The next step after that is to irrigate with warm water so that you can try and that can help actually stopping the bleeding as well. But it also helps you be able to get better visualization in the nose. So after that, basically all of these steps are things that if it doesn't stop with that, these are the next steps that you'll go to. So silver nitrate is actually, it's like a fluid that you can apply to the nose. I haven't actually seen that done, but I've seen it done on like babies for like their umbilical stumps and stuff like that. So you can actually, they come on like a Q-tip type thing, and it's something that you can apply to the nose. Along with silver nitrate, it's often paired with like using a cautery in the nose to actually like burn the vessel so it stops bleeding. One tip with that though is that if they're having bleeding in both nares, you don't want to cauterize the septum on both sides, because that can lead to ischemia and like septal ischemia. And so it talked about that a little bit in the article as like a complication. And so you wouldn't want to cauterize on both sides. If they're having bleeding, you would want to try other techniques or just cauterize on one side. Then in the article, it talked about using like tampons or different packing that they have. Actually, in the article, it talked about how sometimes you can use a Foley, like a Foley balloon, where you basically like put it in the nose and then like pump it up basically, and that like can be used as packing in itself. So I thought that was really interesting, and I've never seen that, but I thought that was way more interesting than the tampon. Additionally, you can use nasal sprays like Afrin. I've also seen like phenylephrine talked about as like a nasal spray that you can use to help constrict the vessel to try and get hemostasis. You can use like gels or solutions on the tampon. So I think that those are things that we would like feel more comfortable with, but I think that whenever you think about like bleeding that can't be stopped by these measures or more complicated patients, I think that's where epistaxis kind of like goes off the deep end and we're a little bit less comfortable with what to do. So what would be some things that you would think about for like an epistaxis patient that you might need to actually admit them, or they might need like a higher level of care for a long period of time?
Maybe if they have a known bleeding disorder, maybe if they have complications from that already, I might ask about it. Or like I said, if we figure out that their nose is not the only part that they're bleeding from, for sure. You know, if we stop the bleeding and his blood pressure is still dropping or whatever, if his vitals aren't stable, then that would make me more likely to see if he could stay at least overnight. I'm not sure about what somebody could come in with just a nosebleed that would lead to them staying long term, but yeah.
I would also be worried about someone who can't protect their airway, just in general, due to like other issues. Because if they do start rebleeding, they might not be in the ED, and so I'd want to like monitor and make sure the bleeding is under control before I discharge them.
I think that's good.
And I think you also have to admit patients who you do posterior nasal packing to. Anterior, I think you can discharge with close follow-up, but posterior, I think you have to admit with telemetry monitoring.
Yes. Okay, so that's the main thing about admission that I had no idea about this. But for patients that have posterior packing, they are at risk to have like a bradyarrhythmia with the posterior packing. And then they're also at risk for airway compromise. So those are patients that have to be admitted every time. Also, if the patient is like hemodynamically unstable or they have significant hypotension, those are really good times that you would want to admit them. If they have other complications, for sure, we mentioned we would want to admit them. Like if they turn out to also like have a GI bleed or they also have something else, we definitely want to admit those patients as well. So then there are other times that we don't necessarily need to admit the patient, but we do want, the patient is more complicated still, so we want to consult ENT. So sometimes that might be the case are if the bleeding doesn't stop with like pressure, irrigation, cautery, silver nitrate. Those are times that you would want to contact ENT because they're going to be able to like possibly the patient might need to go to surgery or something like that to stop the bleed with embolization or other techniques that they use. Also, if the patient has like specific hemoc complaints, like if they have like hemophilia or if they have like hereditary like telangiectasia, then those things are really important for you to contact ENT for. If you think they might have a neoplasm, that's another reason. And then also for structural abnormalities. So if you're examining them and you notice like abnormalities or like a mass in the nose or something like that, that's definitely something that you'd want to contact ENT for. And then also another reason to contact ENT is kind of my last point with their packing. So if they develop a complication from packing, or if they go home and they come back to the ED with a complication from packing, or if they had packing at home and they come in with a complication. So if you do some kind of packing in the ED, how long do you think packing should be left in the nose for? Not long.
If it's a tampon,
Like 3 to 5 days.
Like a tampon? So like 4 hours? No more.
Yeah, so basically the paper talked about these complications happen most often if it's left in for more than 24 hours, which I can't really see any, like most people leaving in the same packing for more than 24 hours. But you have to think that that's how important it is to educate your patient on what's going on and involve them in their care, because they might not know and they might not have any idea and they're just following your instructions, which you just said to keep the packing in, and so now they never take it out and they just get some kind of complication. So complications that can come from that are obviously infection. They could get an infection in their nose. They could eventually become septic because of that. And then they also can get pressure necrosis in the nose if the packing is too tight, or if you're really it should be tight if you're trying to achieve hemostasis and you're trying to adequately stop the bleed. It should be tight, but if left in for too long, can cause pressure necrosis. You can also get toxic shock syndrome, which everyone talks about with tampons anyway, so it's very easy complication to think of and associate with that. So if you suspect that with your patient, that would be another reason to consult ENT. And then obviously a complication they can have with packing is airway compromise if it gets back too far, if they have other issues. So if we think back about our case again, just to remind, it's a patient who is elderly. He's got a lot of risk factors, cardiac risk factors, and he comes in with bleeding for 4 hours. So what are the steps that we would try to take for this patient to stop his bleeding?
The pressure and irrigate and all the stuff that's on the screen.
Yeah, so that's the main thing I wanted y'all to get out of this. If you don't remember anything else, you can remember this mnemonic, and it will help you in the ED. Try to remember what you can do as far as treatment for your epistaxis patients. Okay, so that's pretty much all I have. What questions do y'all have, if any, about epistaxis patients or anything else that we went over?